Hello, my name is Cate Fitzgerald and I'm the Statewide Clinical Education and Training Program Manager for Occupational Therapy in Queensland Health. This presentation is fourth in the series on clinical decision making. It discusses how health professionals can support the decision making of novice learners as a clinical educator or a supervisor. Health professionals often take on the role of clinical educator or supervisor of students or staff who are new to a practice or clinical area. In this presentation, students or new staff are also called novice learners. When supporting the clinical decision-making of novice learners or students, we're encouraged to consider that they often come to healthcare environments with limited professional knowledge and some theory. They have knowledge or notions of how that theory is applied in practice as they've learnt professional models or frames of reference for practice during their studies. However, they have limited skills for translation of that knowledge or theory into practice. Novice learners and students come with some experience of communicating their theory and practice, for example via literature reviews, student group discussions and reports. However, they're generally not aware of how to effectively communicate that in dynamic healthcare settings. Novice learners have limited experience of patient or client interactions, limited knowledge of healthcare environments and their impact on care decisions, and it's not uncommon for these learners to be challenged by what we call ideal versus possible thinking as they engage in care and as they reflect on clinical decision making. We also need to be mindful that novice learners have limited experience of the consequences of clinical decision making. That is, experience of getting it right or making mistakes. So with that general information on novice learners in mind, here are some typical characteristics of their clinical decision making. Typically, novices make clinical decisions by recognising objective facts and features and then using learned or available rules to determine actions based on those facts and features. Typically, they use a linear approach to their clinical reasoning and they need extra time to plan for clinical encounters and are more likely to seek support to guide their reasoning. Novices experience uncertainty around when to break any decision-making rules. In other words, their reasoning may be less flexible and less able to adapt to the unexpected or to new information that's contrary to the decision-making rules they've learnt. Novice learners can identify a list of problems or needs for a client, yet they often have difficulty deciding on what's the most important to work on and why, and they can be challenged to prioritise care decision-making. In contrast to novice learners, clinical educators may be considered experts or competent at clinical decision-making. At the very least, they're developing expertise beyond the level of the novice learner or student. Health professionals are more expert at clinical decision-making because they know what to do and how to reason in practice based on mature, practiced and supervised understanding. As described in the third presentation of this series, experts tend to act without having to think about it and often say they just know what to do based on expertise because they use what is called tacit knowledge, that is knowledge understood or implied. They tend to access more unconscious cues from the clinical environment and are more intuitive in their reasoning, using a non-linear approach to decision-making and practice. They display a tendency to be more flexible in their use of formal and tacit knowledge. While experts are more confident in their reasoning, they may find it harder to articulate their reasoning due to their use of this tacit knowledge. Importantly, experts will tend to deliberate before acting when outcomes are critical, and therefore reflect more for action and more routinely reflect than novice learners. So given the differences between the way novice learners approach clinical decision making and the decision making of their more expert educators or supervisors, it's easy to see that supporting students to develop their decision making in practice needs to be planned for within clinical placements. Let's now discuss a range of supervision strategies to support students to develop their clinical decision making, namely reflective practice, articulating reasoning in practice or supervision, using coaching questions, using structured tools to prompt reasoning, and providing learner-centered feedback. Reflective practice enables learning from experience. Within a clinical environment, there are many opportunities for students or learners to reflect on practice and to be encouraged to do this by their educators and supervisors. Students can be guided to reflect for action when they're requested to plan ahead for what they're going to do, or guided to reflect in action when they're encouraged to think and critically evaluate their care whilst with patients or clients. In addition, they can be supported to reflect on action by responding to questions such as, how did that go? What would have made it work better? And what will you do differently next time? Reflection is a key strategy to guide students to develop their clinical decision-making skills. Students cannot learn clinical decision-making by just observing the actions of their educators and supervisors in clinical environments, because the thinking of expert health professionals is not always self-evident. In supervision, or where appropriate during a clinical interaction, think out loud and more explicitly go over your thought processes as you treat clients or discuss cases in supervision. This is an important learning strategy supporting students to develop their decision-making skills. Other ways to articulate clinical decision-making include descriptions of your patterns of thinking and usual decision rules guiding your thinking about care decisions. Storytelling about past or current clients and how that story relates to the current care scenario helps students understand links in your decision-making and thinking processes. Describing successful and challenging patient stories supports students to learn vicariously from your expert practice. Coaching questions, when used routinely in supervision, support students to develop their decision-making skills as they guide students to recognise their dominant thinking patterns. They guide students to notice if these patterns are supporting or constraining their decision-making. Coaching questions also encourage students to generate as many alternative ideas as possible for client care, and they support students to think laterally, encouraging students to not limit or close their thinking too prematurely. Often, the exploration of incorrect ideas through coaching questions can lead to the emergence of better ideas or the correct ones from the student in supervision. Overall, asking how, what, when, where and why questions as coaching questions during supervision can develop the student's decision-making skills. Another strategy for supervision is to guide students to use structured decision-making tools. We now know that rules and planning are important for novice learners or students. Structured learning tools assist students to identify any decision-making rules they've learnt, and they provide a template for the students to plan and reflect on those rules. Examples of structured learning tools are decision-making diagrams, clinical reasoning worksheets, reflective practice templates, prompt cards with coaching questions suited to your practice setting, flowcharts, mind maps, or other guiding templates developed locally or by your profession. Supervisors can develop these with their students, or students can develop them together. It's been shown that students respond well to these structured tools, as these tools can visually represent reasoning. They provide prompts which guide thinking, and they make sure that most important information is considered and that this information is organised logically. Overall, tools give students time to plan and reflect and can assist them to move on to the next stage in their thinking. Clear constructive feedback during supervision is critical to developing the decision-making of novice learners or students. Learner-centred feedback encourages students to use critical thinking and to reflect on the feedback they receive. Interestingly, studies show that typically supervisors do 90% of the talking in supervision sessions. Whilst this may seem plausible if supervision is used to give feedback, the notion of developing the clinical decision-making of students requires the students to co-construct their learning about decision-making in response to feedback and to develop plans for action from the feedback they receive. Learner-centred feedback does this. It focuses on engaging the learner in the feedback discussion so that they are active participants, so that they attend to feedback, they develop a plan from it, and then have the opportunity to report back on the outcomes of their learning plan. By doing this, the supervisor and student close the loop in supervision. The feedback discussion moves from inputs on to processes, as there is discussion on how the feedback will guide learning and plans for future learning. In summary, when developing the clinical decision-making capabilities of students, consider the difference between clinical decision-making of experts and novice learners. Consider using strategies and supervision that encourage safe reflective practice. Use learner-centered feedback. Use coaching questions and structured tools for developing capability. And finally, take every opportunity to articulate or share your clinical decision-making for client care. To reflect further, I encourage you to think on the following questions related to the content of this presentation. What have you noticed when comparing your clinical decision-making to that of students? How do you use reflective practice when educating or supervising students? How can you challenge a student's habitual responses in their clinical decision-making and encourage them to think more laterally? And how could you construct feedback so that it can inform and guide a student's future practice? Thank you for your reflections, and thank you for listening to this presentation.